All right, folks, we're going to resume, get the afternoon going. Let me stop my music playlist here. Okay, I'm hoping that our audio-visual woes have come to an end. So for this, let me get my okay. So we're going to move on to our key driver focus. It's really focused on warm handoffs or transition to the outpatient setting, into pediatric care. And so I am really excited to have both doctors Woodard, Gilmartin, and Kathleen Hannan. Before their presentation, I'm just going to give a really brief overview about where CHoSEN Quick is going, recognizing that we have been in existence since 2017, and we need to adapt to growing needs and changing needs that we're now facing. So by way of introduction, I would like to provide some details about our two presenters. So Dr. Woodard Gilmartin is an assistant professor at the University of Colorado with a dual appointment in general pediatrics and the KEM Center, where she serves as the assistant clinical medical director of the Child's Health Clinic at Children's Hospital Colorado and as the medical director for the new Children's Hospital Colorado Foster Care Clinic called Kids in Care Settings, or KICS Clinic, and you'll hear a lot about that. Prior to coming to Colorado, Dr. Gilmartin worked at Evanston Regional Hospital in Evanston, Wyoming, where she served as the medical director of pediatrics and chief of the medical staff. She also currently serves as the co-investigator for the Pediatric Integrated Post-Trauma Services SAMHSA grant that's working to disseminate pediatric traumatic stress care process model and to develop enhanced implementation strategies for trauma screening and treatment referral in rural settings and adaptations for the unique needs of children in foster care. Dr. Kathleen Hannan is an instructor of pediatrics in the section of neonatology at the University of Colorado. She completed her medical schooling at the Medical College of Wisconsin, did both pediatric residency and neonatology fellowship here at the University of Colorado. And in addition to her role as a neonatologist, she's actually only one of two neonatologists on our campus that actually sees patients in the outpatient setting. She sees infants after NICU graduation for follow-up care in the special care clinic. And her scholarly interests include outcomes and care of medically complex and technology-dependent infants, including those who have had prenatal substance exposure. So, really a wealth of expertise from these two speakers. Now I'm going to get us started in this first part talking about sustainability. So raise your hand if you have been involved in CHoSEN Quick since the very beginning, say 2017, 2018-ish. Okay. Raise your hand if you've heard of Eat, Sleep, Console. That's amazing. You all have heard of Eat, Sleep, Console. I can tell you that when this work started in 2017, very few people in Colorado knew what ESC was. And now there's been a huge paradigm shift in how we treat substance-exposed newborns. And that's really shown in our data, right? So I showed this at the beginning of our day. We have our process control chart for length of stay of all substance-exposed newborns. We saw a dramatic decline early on with implementation of ESC approaches and reduced need for pharmacologic treatment, shown here again. And that new mean that we achieved for both length of stay and pharm treatment has been sustained since that initial decline. So it's literally been years since we've had this reduced length of stay and reduced need for pharm treatment. And so this was the paper that we published several years ago based upon the early few years of the work, based on data from 2017 to 2019. And what we've come to realize is that for several hospitals, this really has become standard of care. And there's got to be a different way we approach hospital-based care for substance-exposed newborns. And by different, I don't mean moving away from ESC, but really, do hospitals that have been doing this work for years, that have had sustained change, and where ESC is standard of care, do they really need to be, say, entering data on a quarterly basis, looking at their data over and over again, when in fact this is their care paradigm in their hospital? So for hospitals that have been engaged for several years, where ESC and related care practices are truly considered routine or quote unquote standard of care, I'm going to use air quotes now, that's Lori's Halmo's favorite phrase, I'm going to steal that from her, for all SENs, we're going to think about transitioning to the sustainability phase, right? So the eligibility criteria for hospitals that would move into this phase are, again, standard of care with ESC and non-farm optimized. The outcome measures of sustained improvement, like length of stay, need for FARF treatment, persist for more than 6 months. So if you've seen a dramatic decline in those two things, that change has been in existence and continues for more than 6 months, you may want to consider moving into sustainability. And then for smaller chosen sites with lower SEN volumes, you may just have a lot of variability in your data, and you may not necessarily see the usual kind of process control changes in means, etc. And so really, you can come talk to us and see if you're ready. So what does sustainability approach look like? First is the data collection frequency. We recognize that everyone's bandwidth is very limited, and therefore hospitals that are eligible for sustainability will be decreasing their data collection frequency to either semi-annual or annual, or you may want to consider establishing a set number of maternal infant dyads that you're going to include in your data system. The critical piece of this is that it's got to be an unbiased estimate, right? So you can't say, I'm going to pick the 5 SENs who did really well. Or you can't say, like, I'm going to just look at SENs who come in the summertime. Like, there can't be sort of a bias. There's got to be some random sampling approach so that even in the limited data that you're collecting, it's still representing your care practice and outcomes of your units. We have a shorter list of data elements for you in this sustainability approach. And that this doesn't mean that you have any less access to what's already existing. So there's continued data analyses and development of these great process control charts that will be returned to you in a timely fashion. We continue to have support if you want to actually review your data, think about where you can have additional focus if there are some process control measures that are going in the wrong direction. You have ongoing access to the forums, site visits, educational materials, clinical tools, and expert consultation. So if you think your birthing hospital has been doing this work for some time and want to transition to the sustainability mode, please reach out to me or to Rebecca Guili, and we'll chat with you to figure out how we make this happen. All right, so we've done a lot of great work on the hospital setting. So what's next? So again, I'm going to share with you a few data slides that I showed early on. This is the percentage of mothers that are receiving some amount of medication-assisted treatment. We emphasize that this is definitely an overestimate because our definition for it is quite liberal, but we have made no improvements in this in our maternal infant dyad group within CHoSEN Quick. So it's hovering around 50%. Again, to highlight, antenatal consults are awful. We have very, very few families that are receiving anticipatory guidance around substance-exposed newborn care. And EI referrals, while we saw some increase in the first few years after CHoSEN Quick, it's again starting to decline. And so lots of work that is needed around transitions. The warm handoff to the PCP, again, far from optimal, and in fact seems like there's a downward trend in the most recent quarters. And so for all these reasons, given that hospital-based care of substance-exposed newborns with respect to ESC and non-farm approaches have really sustained their impact, we do want to think about what is next and how do we optimize transition. So really the focus moving on is how do we support families starting in the home in the prenatal period through the transition to the birth hospitalization, and then following birth, the transition back to home to the outpatient setting. And so while CHoSEN 1.0, which is what we're calling it, which was birth hospitalization focus, was focused on ESC, non-farm optimization, standardizing farm therapy, and then now sustainability. CHoSEN 2.0 is really focused on optimizing transitions, on engaging outpatient providers, implementing plans of safe care, toxicology testing guidance, as well as implementation, perinatal cannabis use guidance, and then naloxone distribution. So these are the 5 areas that we're focusing on for 2.0 and that you will hear a lot about for the remainder of the afternoon. So we have revised our key driver diagram. This is our 2.0 version, and we're going to go through each of the drivers in more detail. The first thing that I'll say is that the overall project goal for this 2.0 is to improve transitions of care and outcomes of substance-exposed newborns, with the primary aims focused on improving prenatal, birth hospitalization, and post-discharge engagement of birthing individuals affected by substance use, and then 2, improving the safe discharge of substance-exposed newborns. So it feels quite a massive effort, right? So for most, I would say, neonatologists, obstetricians, hospital-based providers, the hospital is a very controlled environment that we have control over, and we know more or less what to expect. When we think about what occurs outside of the hospital setting, it becomes way more challenging and somewhat overwhelming. And I think that's what we've dealt with since CHoSEN started. Like, if you recall, for those of you that have been coming to these forums repeatedly, that EI referral, antenatal consultation, those process control charts I've been showing now for like 6 years. And nearly at every forum, I say how awful those percentages are. And yet we've tried, on the edges to address it without much improvement. So now we decided we're going to try to go all in. Now, with that, I love this quote from FDR. There are many ways of going forward, but only one way of standing still, right? Because I'm not sure how all this is going to play out, but we're trying to move forward and not just show the same process control charts and say we're trying to do X, Y, and Z, but really we're going all in this time. So I have multiple dotted arrows here because I know that there's a lot of different ways that we could tackle this. And the way that we at CHoSEN Quick have decided to approach it is based on first data on where there are needs, in stakeholder engagement, speaking to those in the community, and to be honest with you, third, the expertise that we have within our steering committee leadership group. So this is the first driver. This is focused on increasing engagement with outpatient providers. Within the CHoSEN Quick Steering Committee, for quite some time, we had no representation from an outpatient provider. And I'm really thrilled to say that Dr. Gilmartin has joined our leadership team. And finally, I'm hoping, and I've met a new provider from Fort Collins up there, and I'm hoping that you'll join our effort as well as we really engage providers in the outpatient setting. And so as part of this effort, we hope to develop care transition guidelines. So we're talking about plans of safe care here, engaging outpatient providers in educational and QI opportunities, pilot testing these plans of safe care guidelines. And today you'll hear a lot more about the KICS Clinic and then how do we adapt these plans of safe care for our medically complex substance exposed newborns. The second driver is focusing on, gosh, my eyesight is so bad that it takes me a while to look at my own slides, is developing, operationalizing, and disseminating CHoSEN plans of safe care. Now, I put in CHoSEN plans of safe care because I recognize that the one that you just heard about from child welfare hasn't, it's not official yet, right? It hasn't been given the green light to disseminate broadly. So with recognizing that we have a CHoSEN plans of safe care guideline that Lauren and many others have developed that's actually active in some hospitals like Denver Health and the university. So we would love to implement that at more sites and broadly disseminate it. And we want to make sure that we're doing it in collaboration with other agencies, since lots of different organizations are involved in this space. And then we absolutely want to work very closely with child welfare in thinking about how we bring all these different versions of plans of safe care together so it's not so confusing for providers that are doing this work. Third driver is focused on developing, disseminating, and then operationalizing the toxicology testing guidelines that you just heard about. And so here I have finalized, but it sounds like it's been finalized. Yes, nod, Lori. Yeah. The tox. Okay, all right. There's a little. Okay. All right. So it's close. And so how can CHoSEN Quick disseminate these guidelines? And then most importantly, pilot test. The importance of pilot testing is that it provides us data and experience with operationalizing the guidelines. How do we reduce the gap between guidelines that are evidence-based and what we do at the bedside? So this pilot testing piece is really important. And we want to get really granular qualitative and quantitative data as we roll these guidelines out. Fourth is developing, disseminating, and operationalizing perinatal cannabis-related recommendations. Not a controversial topic at all, right? Oh my God. So I know many of us in the room have been reviewing the various iterations of these guidelines that have been circulated. I do not envy the position that Jessica Bass and others from CDPHE are in trying to bring all the different stakeholders together to agree upon a set of guidelines that we all feel comfortable then operationalizing and disseminating. So that work is ongoing. I think a agreed upon final version will come in the next several months. And really, CHoSEN Quick would love to assist in disseminating the guidelines. And we have been given reassurances that these guidelines will be very much in line with what our professional organizations support, so AAP and ACOG. And again, critical piece, pilot testing and operationalizing these guidelines at 1 or 2 local sites to understand how those with lived experience, providers are feeling about these guidelines that are going to be in place. And then lastly, naloxone distribution. I am so thankful to Don Stater and the work that he continues to do and the sort of exponential expansion of naloxone distributions that's taken place in our state, and how our perinatal community has been so eager and excited to collaborate with Don and his group. And so as you'll hear later on, we want to be able to disseminate naloxone, the actual naloxone, and then also distribution guidelines across our birthing hospitals. And again, the pilot testing, operationalization of these guidelines. I know I sound like a broken record, but this is the critical piece. When I first met Don last year and I attended the workshop of, naloxone distribution, engagement, etc. And at the end of it, I actually asked Don, I don't know what naloxone looks like. I've never given it. I actually know what it is, but I don't know anything else about it. So there's clearly this disconnect, right? Even for myself, someone who's been in this substance exposed newborn space for quite some time. So of course, he so very kindly took one out from his backpack and handed it to me. But today we will receive more training. And so again, to bring home the message that CHoSEN 1.0 was really birth hospital focused. For those of you where the birth hospital piece is something where you haven't yet engaged in the work, please reach out to us. We're not doing away with it. It's going to be this and 2.0. Okay. So if you're new, let's get you plugged in. If you're old and want to do sustainability, let me know. And then for everybody else, let's move on to optimizing transitions. Okay. And with that, I'd love to welcome Dr. Bird Gilmartin.
Thanks, Susan. Like she said, I'm Bird Gilmartin. I am thrilled to be here with you all today. I am a general pediatrician and the medical director for the Kids in Care Settings Clinic, or the KICS Clinic. Our learning objectives for today are to communicate about the history and development of the KICS Clinic, to outline some of the special care components the KICS Clinic will offer, and to present some of the key collaborations the KICS Clinic has, including with CHoSEN Quick. But I'd like to first start with a story. And for the purposes of this story, we're going to call the infant Ricardo. Ricardo was born prenatally substance exposed, and shortly after his birth, his mother left the hospital against medical advice, and she's not been able to be contacted since. Ricardo was placed into protective custody, and as their mandate dictates, child welfare used resources to find next of kin to place him with. And they were able to find one of his grandmothers, and she agreed to take Ricardo. To give you some background on Ricardo's grandmother and where she was at in her life when DHS contacted her about Ricardo, she was recently widowed. She had lost touch with her child and didn't know she was going to be a grandmother until the caseworker contacted her. She had physical and health limitations of her own, transportation concerns, food insecurity. She did not have a washer or dryer in her apartment or apartment complex, and she was already experiencing economic and financial hardship. Ricardo had some medical complexity of his own. He experienced withdrawal. He was difficult to feed and took long times to feed. and was struggling with gaining weight, and he was discharged on oxygen. So now, on top of Ricardo's grandmother's previous stressors, she had to navigate oxygen. She had to feed a baby that was hard to feed and had lots of laundry needs and difficulty accessing those laundry needs. He had dysregulated sleep, and it was hard for her to get up with him all those times in the night that he needed that care. She had to find a pediatrician. She had multiple court dates, frequent appointments with caseworkers. Ricardo had lots of healthcare appointments. She had lots of healthcare appointments, and every single one of these appointments required transportation that was a challenge for her. So in an already fraught and difficult situation, Ricardo added more complexity. Ricardo's grandmother could have benefited from some hand-holding, community resources, a one-stop place where she could go and get the supports that she needed, where trained healthcare experts could be there to support her in successfully helping to raise Ricardo. Unfortunately, Ricardo's grandmother did not have those supports, and she relinquished Ricardo's rights back to DHS, and he was placed in formal foster care custody. And we'll circle back to Ricardo and his grandmother at the end of this. So this is a timeline of the 17 months that we've used to develop the KICS Clinic, and some of the key components and steps and connections and people and projects that have all gone into the opening of this clinic. And this is by no means exhaustive, but you can see that there's been a lot of touch points throughout. The vision of the KICS Clinic is children, youth, and families involved in out-of-home placements, leading healthy, resilient lives with empowerment and hope. I know that this is a busy slide, but it demonstrates key feedback we got from partners with lived experience. We felt it was important as part of the development process for KICS to gain perspectives of people with lived experience about what would be the most helpful, welcoming, and service-oriented primary care clinic possible. We were fortunate to be able to conduct 17 interviews with 4 key groups of partners, including youth involved with child welfare, families whose children were in child welfare custody secondary to substance use disorder, county DHS agencies, and fostering kinship families. 5 themes emerged across these partners: improved communication across all the systems, coordination and integration of care in a single medical home, so essentially having one place where all your needs could be met, trauma-informed care and trauma-specific services, mental and behavioral health services and resources, and all patients and family types feeling respected and not judged when receiving care. We use these themes and perspectives to help guide the development of the KICS Clinic. So what are some of the key components of the KICS Clinic? As I've said, it will serve as a medical home model, so a primary care clinic. It is starting small as a pilot. We will serve all pediatric age groups, 0 to 18 years of age. We'll have integrated mental and behavioral health, a trauma-informed lens, an interdisciplinary team, and longer appointment times to help facilitate being able to address the complex needs that these patients and families often have. So the interdisciplinary team will consist of a pediatrician, a psychologist, behavioral health navigator, social worker, nurse care coordinator, community health navigator, a dedicated scheduler, medical assistants, and we'll also have child life specialists available when needed. There will be 2 referral sources for the KICS Clinic when we first start. The first will be Arapahoe County Department of Human Services. We will be serving children that are in out-of-home placement, either foster care or kinship care, that have been formally removed with the dependency and neglect court filing proceeding. There will be some component of substance exposure. That might be that the infant is prenatally exposed, there is manufacturing in the home, one of the family members has substance use disorder as part of a contributing factor to the case. So very loose, but some kind of substance exposure. New placements, and will serve all ages. Our second referral source will be the University of Colorado as the chosen quick participating hospital, their newborn nursery and NICU. And again, we'll be serving infants that are prenatally substance exposed that are in out-of-home placement in foster care or kinship care. So some just base logistics. The clinic opened this week and it is on Monday afternoons. And it's housed at the Children's Hospital Colorado's Health Pavilion, which is where the majority of the primary care clinics for children's resides. There's a few special internal collaborations that I would like to highlight, and in the following slides, we'll go through those in more detail. So the first is our dental clinic. In addition to requiring medical evaluations upon placement, children entering the child welfare system also require dental examinations, with the standard being to see dentistry within 8 weeks of placement. But dental care can be challenging to access in a timely manner. And in our effort to create a one-stop shop for families and increase access, we've partnered with our dental colleagues. There will be both reserved appointments for KICS Clinic patients as well as coordinated appointments with KICS appointments and dental appointments on the same day for some families. And they will be able to serve all ages. One of their great barriers is consent, and we'll be able to help with that process. And then also we'll be able to improve the medical information they have when they're doing their dental examinations so that they can complete the most comprehensive care and maximize what they're able to do at those appointments. Another collaboration we're excited about and proud of is partnering with our developmental and behavioral pediatrics colleagues. So developmental and behavioral pediatricians are specialists with additional training and certification in the evaluation and management of children, teens, and young adults with a wide variety of developmental and behavioral concerns. And these providers are experts in understanding the complex factors that influence development. Children that are involved with child welfare have a significantly higher rate of developmental and behavioral concerns than the general population. And it can be hard to tease out the interplay between the many possible contributing factors, such as substance exposure, learning differences, attention concerns, neglect, trauma, family medical problems. And sometimes kids would benefit from a more comprehensive assessment of their behavior and development. However, oftentimes these specialized assessments, the wait times are over a year currently. And so we have partnered with developmental and behavioral pediatrics similarly to dentistry, and there will be an expedited and held appointments for patients that are seen in the KICS clinic for these assessments. They will offer a trauma-informed lens, and they will be able to do assessments such as autism spectrum disorders, fetal alcohol spectrum disorders, along with a myriad of other things, but those are some examples. We have also partnered with our Government Affairs and Child Health Advocacy Institute colleagues, and they have helped with coordination with Colorado Access, our RAY, as well as Healthcare Policy and Finance, or HCPF. They have helped to coordinate a three-way collaboration between Colorado Access, Children's Hospital and KICS, and Arapahoe County DHS. They're setting up a process for monitoring reimbursement and denials for this population to try and help create advocacy where that might be needed. And our tri-data analysts are helping with evaluation and outcome measurements for KICS. In addition to these internal collaborations, we have some external community collaborations for the KICS clinic that I would like to call special attention to. The first is CHoSEN Quick. And as Susan alluded to, the KICS clinic will be the preferred medical home for the University of Colorado's CHoSEN hospital. And we'll be helping with those transitions of care that she spoke about. So we'll be partnering in terms of early connection to early intervention services and referrals, following up on postpartum depression screening, both for the foster or kinship family, but also for the biologic families. There will be a feedback loop between the birth hospital and the KICS clinic and the medical home in terms of ongoing opportunities, barriers, as well as successes. And we're partnering with CHoSEN in terms of a qualitative data collection project. We're also partnering with Arapahoe County DHS, and we have a coordinated referral pathway with them. We've partnered with both Children's Legal as well as the county attorneys for Arapahoe County to improve the consent process and streamline that. We also have a monthly feedback loop with them to, again, discuss successes and optimizations and address ongoing barriers. And we're working on launching a software pilot called Identity that allows for real-time communication and exchange of information between healthcare and DHS. And they're part of that three-way collaboration with Colorado Access and Children's. In Colorado, community center boards are the agencies that are responsible for administering services such as early intervention, which is a voluntary educational service for children with a developmental delay between the ages of 0 and 3. And Developmental Pathways is the community center board for Arapahoe County. We've partnered with them to help ensure access for KICS patients to their essential services. So we'll be doing a dual referral process to help expedite the access to these services and still allowing for the valuable care coordination that EI provides. We're coordinating with the Arapahoe County DHS and Developmental Pathways liaison to track and watch these kiddos and also try and assist with the consent piece again. So our commitments at the KICS Clinic are to be trauma informed, to offer comprehensive screening, to continue to work to expand access to services, to include and welcome the participation of the biologic family when possible and appropriate, coordinate services and recommendations with community partners, to remain open to feedback and process changes, and to continue to work on ongoing incorporation of lived experience into the clinic. So if we come full circle back to Ricardo and his grandmother, our hope is that if they could have come to the KICS Clinic, they could have had the supports, tools, and resources and care to successfully stay together. Thank you, and I'm happy to take any questions later on.
Thank you so much, Bird. We're going to do questions at the end. So let me welcome Kathleen up.
Hi, everyone. My name is Kathleen Hannan, as Susan so nicely said previously, and I'm really excited to be here today to share a little bit about some of my passions, which is caring for medically complex infants. So today I'm going to talk a little bit about that intersection between infants who are medically complex and substance exposed. So just to kind of go through what I intend to talk about for you guys today, first I want to make sure to define who children with medical complexity are. There's a lot of different definitions and making sure we're all kind of speaking the same language when I use that term. I also want to talk about what we do and don't know about the overlap between the two kind of different populations, those with medical complexity and those who are substance exposed. I want to give you guys a couple of case examples of some of the really complex cases that we've dealt with in the NICU. And then also talk a little bit about some opportunities for how we can continue to improve the care of these infants, both in the NICU, but really going forth into the post-hospitalization period. So to start out, who are children with medical complexity? Many of us who work in the clinical realm have an idea in our head of who these may be, but actually kind of saying a definition out loud can be a little bit more challenging. The gold standard definition that's used throughout the pediatric literature really relies on a thorough patient and chart review. And these are things that indicate high healthcare use, multiple subspecialists, often some kind of functional limitations, and then often the need for a use of a complex care program. However, this is a pretty time-intensive way to identify these children. So there are more practical definitions that exist, and these often use more administrative definitions. One such is the complex chronic conditions criteria, which also includes a subset of infants who have home technology dependence. And this is a set of validated ICD-9 and ICD-10 codes that help us indicate which infants, or actually this is applied to all children, have conditions that are expected to last at least 1 year and require significant healthcare utilization. And the reason that these infants and children are important to identify is that they're really disproportionately high utilizers of healthcare resources. So children with medical complexity comprise less than 1% of all pediatric patients, but up to 1/3 of all pediatric healthcare costs. So you can really see the disconnect between this really kind of disproportionate utilization of healthcare. And as we see with many different vulnerable populations, this really presents an opportunity to decrease costs and improve outcomes. One such way that has been a focus for the population of children with medical complexity in general is through providing improved care coordination. We know that children with medical complexity are at risks for gaps in care, and this occurs throughout their lifetime. This includes disjointed services with a particular focus on transitions between inpatient and outpatient care, repeat hospitalizations, often of which they can be preventable, medication errors due to complex medical and medication regimens, and really importantly, the high stress and lack of respite that these caregivers have. There's also been a lot of fairly high level, even randomized control trials looking at the effect of care coordination on this population, and it's been shown to be highly effective in its ability to decrease costs, decrease unnecessary healthcare utilization, and improve caregiver and family satisfaction overall. And so I think, really extrapolating the work that has been done in the field of children with medical complexity to include those that are substance exposed infants. And I think about this intersection between the two. It's not very far reaching for all of us, I think, to think about examples of infants who have medical complexity and who are also exposed to substances and vice versa. And really kind of start to think how creatively we can think about some solutions and some interventions to help improve this population. And so I'm just going to take a couple minutes to review a little bit of the data behind who this population may be and where we actually don't have a lot of data. And I don't think I need to tell this group for all that much that the risks of substance exposure includes an increased risk for having to spend time in the NICU. This population is defined many ways, as you all know, but in this particular study, we found that there was 2.5 times the risk of preterm births for mothers with substance use disorder, and this included 3.6 times the risk of low birth weight and 3.8 times the risk of growth restriction. And then some of the work that I've done in the past has looked at very low birth weight infants who are in the NICU and their risk for medical complexity, and have found that over half of those infants have medical complexity. So if you kind of start putting these two populations together, you can see that there is definitely an increased risk for these infants. Similarly, in another study by Ma and colleagues looking specifically at opioid use in a large Medicaid population, this was broken down into whether mothers were on maintenance therapies or had a diagnosis of opioid use disorder, compared to those without any opioid use. And what they found was that mothers both on maintenance therapy and with opioid use disorder had significantly higher rates of NICU admission. And again, looking at one of the few studies that actually specifically looked at medical complexity among infants with substance exposure, this was in a population of newborns from a single county in Ohio where universal infant tox testing was performed over a 4-year period. This allowed them to both look at those who had a clinical diagnosis of NAS and then also subclinical exposure. They first found again that infants with opioid exposure were more likely to be born preterm. But then importantly, they also found that there was a significant increase in the rate of complex chronic conditions amongst the group that had opioid exposure. And this group also wanted to look at some outcomes. So they attempted to kind of try to start to put the pieces together of what are the different factors that affect the care of these infants ongoing and their healthcare utilization. They looked at some clinical factors like term status, having complex chronic conditions, and whether they were in the NICU, a couple of sociodemographic characteristics like race and ethnicity and insurance status. And what you can see here is this is quite a complex diagram. There's a lot of arrows going a lot of different ways. And I think it doesn't take much for us to really conceptualize that these are really complex interactions that do have arrows going a lot of ways with different things affecting different parts of it. And when we looked at some of their outcomes, they found that subclinical exposure compared to unexposed infants was associated with ongoing healthcare utilization. And this is in the form of a 30% increased odds of having at least one hospitalization in the first year of life and a 40% increased odds of having at least one emergency visit in the first year of life. They did find that after adjusting for things like complex chronic conditions in a NICU stay, these findings were no longer significant. They didn't do any further analyses to see kind of what the exact drivers of this were, but this does kind of paint a picture of what is driving some of these outcomes for these infants. And I won't spend a whole lot of time on this as we have just heard quite a bit of information in this realm, but looking specifically at children with medical complexity, almost a quarter of those children have child welfare involvement. And additionally, we know how important the dyad is, and that certain caregiver clinical variables were associated with an increased adjusted and unadjusted odds of having child welfare involvement. And that included mental health problems, chronic medical conditions, and interpersonal violence or trauma. And so bringing this back to our key drivers, I think we can all say that that's great. There's probably this overlap that we don't fully understand. We haven't fully characterized. But what does this have to do with our outpatient providers? And I think that this really offers us an opportunity to think about how we can focus on a certain population, this extra high risk group, and how we can improve their care. And I think one of the important steps of this is through care coordination, access to resources, and then both supporting caregivers and medical providers in that transition from the inpatient to the outpatient world. And with that, I want to talk about a couple of babies that help illustrate a lot of the complexities of this care and how there definitely won't be one solution that really solves this, but how there are many opportunities for us to intervene. So this is a baby who was born extremely prematurely at 26 weeks. This baby was quite sick from the beginning. They had severe lung disease, required the oscillator, which is a specialized high-level ventilator. The baby required a breathing tube for over 6 months, needed actual surgery on her airway to help her breathe, had an ongoing need to have a CPAP machine at night and oxygen during the day at home. The baby also had severe pulmonary hypertension, which complicates the medical course, and wasn't able to feed by mouth, so had a gastrostomy tube or G-tube as well. This baby's, the rest of the history of this baby is that the family was from over 200 miles from Denver. The baby was flown here on the first day of life. Mom had opioid use disorder in pregnancy and was now in treatment, and also had a UTAX that was positive on admission for amphetamines/methamphetamines, which I'll leave to Lori for the interpretation of that. But mom also had a really complex mental health history on multiple medications. Father was involved but incarcerated throughout this NICU hospitalization. Mom had a lot of housing insecurity, initially was able to stay at the Ronald McDonald House, but then was no longer allowed after some violation of rules there. Mom did not have transportation and relied completely upon public transportation and getting rides as she could from her home over 200 miles from Denver. There was an open DHS case throughout this, and mom spent a period of the hospitalization also incarcerated. This baby's medical complexity did not stop in the NICU. On discharge, this baby went home on oxygen during the day and CPAP at night, had a pulse ox monitor that she was supposed to be wearing 24 hours a day, had a feeding tube and a feeding pump, needed emergency medications if she were to get ill that require specialized training to administer. And the list of specialists this infant needed to see was also quite long. So a local pediatrician, care coordination in our special care clinic, pulmonology, cardiology, audiology, endocrinology, ophthalmology, ENT, all of the therapies in addition to feeding therapy. So really a complex course going forward. This baby spent over 8 months in our NICU and was discharged with grandparents with mom still involved. The second case that I'm going to share with you guys today was a baby born, again, extremely prematurely, this time at 24 weeks. Also had a complex respiratory course, needing a lot of respiratory support, needed 2 heart surgeries, had a history of seizures. There was a lot of discussions about whether this baby was going to need a tracheostomy and chronic ventilation at home, but was able to wean to just oxygen, and also needed a G-tube for feedings. The rest of the history for this baby, mom had a history of substance use. She had some methamphetamine use early in pregnancy. However, she stopped using since learning of the pregnancy throughout the NICU stay and continues to be sober today. She had a lot of family support. She had some really strong people surrounding her. And I'll come back to some of the discharge part, but several others in the home did smoke tobacco. DHS was initially involved, but the case was closed. The other complicating factors for this family was that father also had opioid use disorder and some housing insecurity, and there was concerns for interpersonal violence as well. This baby went home on oxygen with a pulse ox as well, also with the G-tube and feeding pump, and also had quite a list of specialists. And this baby spent over 5 months in the NICU and was able to be discharged with mom. There was a lot of discussions about the safe discharge for this baby because mom did have a really wonderful support system around her, but she was very concerned about bringing her infant with severe lung disease into a house where caregivers were smoking. And this was a really big discussion point for us for a really long time, that this was the best place for her mental health, her recovery, and support for her and the baby, but not necessarily the best place medically for the baby to be. And in the end, we were able to make a plan to hopefully help with family member smoking cessation. But of course, there's no guarantees in that realm. And I don't actually know currently where that stands. So when I think about these cases and many others that have different elements of these, some of which we've heard kind of similar realms today, I think about what do these cases actually teach us. And the first thing is that I think that the complexity of these is likely exponential, not additive. So these babies in these cases really illustrate how all of these different layers of complexity make it so challenging for anyone to take care of these infants outside of the hospital. And when families have a lot of their own issues as well, it really makes that complexity even more so. Additionally, these babies are here for a long time. A 5 or 8 month NICU stay is kind of commonplace for us. Not all babies spend that long in the NICU, but many do. And this is incredibly challenging, both for families, for uprooting their lives and living out of a NICU, and then also for outpatient providers who take over the care of these babies, trying to grasp what has gone on over the last 5 months, 8 months, whatever it may be. But at the same time, this is a huge opportunity. We have a captive audience for months and months and months. So a lot of the work that CHoSEN has, successfully done is in a really short time period. A birth hospitalization, these really, finite couple day long things. We have months and months. We have months and months to create connections, to help assist with treatment, for education, and for just overall support. So I think that is really encouraging that we have these opportunities. These cases also teach us how essential handoffs of care are. So both during hospitalization, our baby who was in the hospital for 8 months, that is 16 different neonatologist attending blocks at Children's. So although we may have some repeat in there, they might have 16 different main doctors during that time. And that doesn't include the rest of the team that turns over and comes in and out as well. So there are lots of people involved in the care of these infants while they're in the hospital, and handoffs between those providers is essential. But then when they move from that highly specialized, hands-on environment of the NICU to all of a sudden going home, how do we make sure that that transition is as smooth as possible, and that those resources that we had in one day at the NICU don't immediately disappear the day they go home? And so I wanted to come back to this web of kind of factors affecting opioids or substance use and healthcare utilization and the different things that kind of go into play. And although I think this is a great starting point, and I commend these authors for thinking about this and thinking about different factors, I would say that even the things that I've put up here is still really only the tip of the iceberg. So there are so many different factors, and we could put so many more different arrows in here that really we need to take into account when we're thinking about the care of these infants. And this is not to say that, I wanted to put this up here to be overwhelming. These kids are complex kids with lots and lots of different needs, but I think there are so many different opportunities for intervening on one or two of these arrows at a time to help really to give comprehensive care for these infants. And so what are the next steps? I'm going to echo some things that have already been said in the last little bit. And throughout the day today, but really putting a focus on identifying these high-risk infants to start. A lot of our programs have focused on the infants who either have shorter NICU stays or from the newborn nursery. And sometimes by the time these babies are getting discharged at 5 or 8 months of life, the part of their history that was their substance exposure sometimes isn't at the forefront of the provider's mind, and making sure that we are systematically identifying and making sure that these resources are able to be continued for these families. We heard a little bit about care coordination and the pilot program of following up some of these infants in follow-up, both through the KICS Clinic and through special care clinic. And then really coming back to this enhanced transitions of care. So looking at our plans of safe care, how can we ensure that we systematically sign these infants out, that we make sure that the outpatient providers have an understanding of what went on in the NICU and how these families were supported. And then how can we continue some of these resources for supports? I think about some clinics that, just don't have the bandwidth and don't have the resources to have the social worker in clinic who's able to help coordinate certain things, who's able to nurse care coordinator who's able to act as the coordinator of multiple appointments, all of these things. How can we systematically look to make ways to make this a little bit easier? So I'll end there. Please feel free to reach out to me if you have any thoughts, if you have questions, or if you just have an interest in children with medical complexity and want to talk about more about how we can kind of support these infants. Thank you.
Thank you. For all three I'll get it going. Number of times have so many providers involved. Okay, so your clinic has so many providers involved, and I can't imagine that it's a money maker for the hospital. Recognizing that, how did you do it? I mean, you showed a timeline, right? You showed a list of providers that are involved, but how did you get buy-in and convince the bigwigs, the leaders, that in fact it was worth the investment? I mean, because that is a lot of FTE, a lot of resources, and even to get moved up into dentistry and then behavioral health is huge. I think many of us live in kind of suburban communities, and we probably have friends or even ourselves that are dealing with pediatric mental health issues, and it's nearly impossible to get an appointment in a timely fashion. And yet you've somehow managed to have your patients kind of prioritized. So how did all this come to be? And are there any lessons that we can learn about moving our work forward?
It's working. That's a big question, Susan. I was recruited back to Children's in part to start this clinic. So I did train here, and I, as Susan alluded to in my bio, lived and worked in rural Wyoming for 6 years, where I did the medical physical child abuse evaluations for a large swath of Southwest Wyoming and did trauma initiatives, and then served as the primary care provider for children that were in DHS custody. And in that work, I had to work with lots of different community partners and get buy-in and work with specialists and work with referral centers, because we were a teeny little community hospital that could not do a lot of the care ourselves. And so in that, I learned a lot of lessons about relationships, I think, primarily. And I think, how do you build relationships with people that they want to start playing with you in the sandbox? So, as you said, Susan, this is not a money-making endeavor. But I was fortunate that I entered into my role with buy-in from the Chem Center and buy-in from General Peds, that they wanted to do this joint collaboration. And then from there, I kind of built relationships, and I started with one, and then they knew someone else, and then they knew someone else. And I was fortunate to have lots of amazing touch points with people like Dr. Klee, who helped connect me with some of her patients so that I could hear from them what would have made a difference, and work with Project Foster Source to hear what the youth thought would have made a difference in their healthcare and life trajectories. And from there, you could kind of start to put the pieces together and see, okay, well, we're missing this piece and we're missing this piece. And I'm persistent and annoying. So I also am not good at taking no for an answer. But I think at the heart of all of it, it is relationships and having a vision. And luckily, the Children's Hospital Colorado has a mission to serve children. And you can make a pretty strong case that if we're not serving this population of children, we're really not doing right by our mission. So I fall back on that a lot.
Thank you. Other questions? All right, I'll continue us. So for Kathleen, so you mentioned that the NICU stay is quite long for these infants. What are some things that we could be doing, in the NICU? I'll be honest with you, when we round in the NICU and we know the medical history of some of these infants and we know there's prenatal substance exposure, but rarely do we then ask the next question, well, what's being done to support the family, So what are some things that we could think about?
Yeah, I think this is working now. I think that we rely a lot on our large care teams, and I think a lot of providers kind of say, social work is involved, or, when we have one available, a psychologist is involved with this family, XYZ. And I think that we can change the discourse a little bit to say, as the medical provider, how essential this is to their care and to their discharge planning, which is something that we talk about, all the time in the NICU, and how we can better support them. I think there's also opportunities for us to be a little bit more equitable in how we communicate with our families. The families who have a parent who's able to be there 24 hours a day and sitting by their side gets very different family updates, as you all know, than the family who lives 200 miles from Denver and doesn't have reliable transportation. And so if we're able to make really, concerted efforts to call at the same time, to make a plan, how are we going to communicate the care plan? How are we going to include you in rounds? How are we going to, make them feel just as involved, regardless of what, the DHS side is saying where this baby is going to go? I think could make a big impact.
Are there any folks from child welfare still here? Oh, okay. So the question that I think that we struggle with for these infants that have a prolonged hospital stay, especially if there's some restrictions around parental visitation and it's unclear who the baby will be discharged to, just wondering about the timing of when disposition is determined, when from your end, to whom this infant will be discharged. And I ask that question because for these especially very complex infants, there's so much parental education and caregiver preparation that needs to happen. And when these infants are discharged to kin, these folks do come, like grandparents are there, weeks prior to discharge. But when it's a foster family, it's a really rushed kind of thing that happens and real stressful for everybody involved. So just curious about the process from your end for medically complex infants.
No, that's a great question, Susan. And I think there was a question earlier, maybe from Larimer County, kind of alluding to some of the same things about planning. When you're planning to discharge a kiddo and knowing where that kiddo is going to go, that makes all the difference in the world in your education of the caregiver, not knowing who that is. From a child welfare standpoint, I think it's going to depend a lot case to case, and I'm not the best one to answer that in all full caveats, but it definitely makes sense to me as a physician that understands at least to some degree about child welfare, that the sooner child welfare has an idea of the disposition or where that kiddo is going to go, that should be communicated back to the care team, because that's going to be critical to the education that you're providing to caregivers, families, et cetera. So I don't have a hard answer on exactly when they know with every kiddo, but it definitely is something that seems like it's important for me to take back and kind of press home on the child welfare end, that as soon as they have an idea of where that's going, they should be, with everything else, communicating that really clearly to the care team. Am I understanding that question well? It seems like that's what you're asking, and that I can see how critical that would be to the planning and education.
Yeah, I mean, we find that in experience, though, that designation of who the family is going to be happens a bit too close to discharge, and we're scrambling kind of at the end. Oh no!
To that. Well, it was in lieu to what you were saying. In my experience, and I'm Sharita from St. Joseph's Hospital. I'm a social worker in the women and infants. But in my experience in the NICU with these critical fragile babies, or however medically complex, we've had to fight for the GAL, guardian ad litem, to actually allow the foster family or identified family member, or not family member, but foster care family member, to come in as they will be the placement, but there's not the custody that has happened yet. So it's been pretty tricky because they believe, and by they I mean in my experience, the county, that the baby is safe because the baby is still in the hospital. So there really isn't an emergent situation to find placement. So I think that's kind of a barrier.
Lori over there with her hand.
Thanks. I was just going to add on that note, I totally agree with everything you just said. The other thing I have been told off the record is that once the county takes custody, that's when they have to start paying the foster parent. And they don't want to pay the foster parent until the foster parent actually has the kid in their care at home. So this happened when we took placement for our youngest, who was medically complex and was in the NICU. Thankfully not for 8 months, but we got the call that he was being discharged and could we go please pick him up immediately. And also PS, he's medically complex and we need to learn how to feed him and all these things with the special feeding system and blah, blah, blah. And I was like, yo, it's like 3 p.m. Good luck. And so I kind of was like, where was the heads up here? And that's what I was told. So from our perspective as, medical providers, so I don't know how effective this will be, but I think, explicitly saying, this is the difference between discharge on this day or discharge on that day. Sometimes that level of concreteness gets it sort of through the other end. But for whatever that's worth, I've been told that's a barrier.
And I'm a pediatrician. I thought in our clinic, we are down in Douglas County, we are the only ones that take in foster kids. We're the only ones that take Medicaid. And so we actually had it actually doesn't exist anymore, but we had for many years a foster care clinic where we actually had the social worker in there. They had extended a lot so it was all the foster kids. But what happens with the pediatrician is a lot of times the foster families are found at the very last minute, but they don't know who their pediatrician is going to be. So we never got notified. The foster family would come in with this extremely, this thick discharge summary, and we never spoke to a neonatologist or the people who took care of them in the hospital because the foster family was found at the last minute, and then they had to find a pediatrician. A lot of times they would pick one, they find out, doesn't take Medicaid, so they can't go there as a foster child. So there's a huge disconnect with these complicated kids and their foster care and the pediatrician that's going to be taking care of them for a very long time. And somehow that's got to get fixed. I don't know how.
It's interesting.
Stephanie Bork, neonatologist at Children's, and I will echo what Lori said. I was the discharging attending for her foster baby. I was on call that night and got, kind of a frantic message from our medical team saying we have to discharge this baby right now. Lori is a very well resourced, educated person that can come in and learn these things, but I think regardless of the situation, that is not ideal for the foster family. It's not ideal for the medical team. It's also not a good use of hospital resources to keep infants in a level 4 ICU to discharge them. And you could say, well, they should go to the floor, they should go to acute care, they should go somewhere else. That is not the place to be transferring these medically complex infants just for discharge planning when we can do a really good job at it if we know where the baby's going to go and to whom the baby's going to go. But discharge planning is very complex for every NICU baby, for every late preterm baby. And you can just add on the number of specialists that Kathleen mentioned for these cases. It gets very complicated and there's a lot of people involved. And now you can see how things fall through the cracks.
Be aware of as well, or
she answered it. Oh, okay. So the question was, why? Why was it so last minute? And Steph was saying that we didn't have a reason to keep the baby. We were really just waiting for a foster parent, which apparently was Lori.
And I think that, Erica Hwang, we're also neonatologists. I think that all of the clinicians in the room that are discharging these babies have experienced this where we are waiting for the baby to be medically ready to go home. And then we hear from our case manager, social worker who's communicating with CPS of saying, we haven't identified the foster care until you tell us the baby's ready. And then it's always the expectation that happens within 4 hours. And I think the disconnect needs to be, babies are not medically ready until what several times it's been presented today, and we've been talking about this for all of our forums, is that we have 2 caregivers that are ready and trained and available and know this baby. So I don't know why that's not part of the criteria of medical readiness, is that a family has to be identified and has to be present. Right. Right. Exactly. Right. Exactly. Right. That's what I'm saying, is that when we say that criteria of medical readiness from CPS's perspective of when they assign somebody is not including the fact that part of medical readiness is assigning somebody so that they can be there. And so that's where we need to change the policies, where we have more collaboration of medical readiness includes an identification of a family, and that family is present, or whomever it's going to be, the caregivers, they're present, they're trained with adequate time to learn how to take care of this child, whether or not they have G-tube feeds, et cetera. A baby with substance exposure is challenging. Okay, thank you.
I just was curious. This is totally, I am not a neonatologist and frankly don't spend very much time in the hospital. I'm all in the outpatient setting. But I was thinking about kind of the wisdom that we've heard from so many different aspects of taking care of families impacted by substance use, of the need for parent advocates and peer support specialists. And I'm wondering what exists in the NICU world to help these families, right? Because this is not, it's not a unique situation, right? And so I'm wondering about kind of peer resources that I could start teeing up in the outpatient setting prenatally when, sometimes we know ahead of time, like their baby's going to have, is going to need heart surgery within the first couple of days of life or things like that. We know ahead of time. What's out there? Or who wants to pay for
Susan
it?
could probably speak most
Yeah,
of this. I know a little bit, but
I would say, even in the best case scenario, right? We're not even talking about substance exposure. We're just talking about care in the NICU. I think we have lots of barriers around family support and family engagement, and we're far from there. So some of the efforts, though, that we are thinking about are improved maternal mental health screening, treatment in the NICU versus, having families go elsewhere remote. We're focusing on peer support, specialists, those that have lived experience with ICU in a more remote time that are now supporting currently hospitalized families. That's not universally available. And I think it's fairly limited. Now, then we add on top of that prenatal substance use, along with the whole host of other social determinants of health that go along with that, right? And so I think there are some places that do it better than others, but it's really in its infancy. So one thing that, is developing is the perinatal navigator program, right? So CHoSEN, along with the Chem Center and others, are looking to develop a navigator program that would engage with these families in the prenatal period through the first year postpartum. And not an insignificant number of them will be involved, in receiving NICU care. And so there would be continued support with the navigator through neonatal hospitalization. We're not there. And so at this point, I would say in the NICU, from the medical standpoint, we often defer to our social workers and case managers to then make these appropriate referrals. But I'll be honest with you, I don't know the frequency of referrals made and then accepted and then followed through. And I don't know about the effectiveness of the interaction, between these different services and the families that they're serving. So it's a bit of a black box to me, at least. Yeah. Other questions? I saw some hands up. I think Jade, did you want to say something?
Had a quick comment. I think there's also the perspective of not identifying a foster family until we're certain that that bio family isn't going to be safe. And if a baby's in the NICU for 8 months and parents are working a program and getting treatment, they might be perfectly safe by the time that that baby is ready to go home. And we don't want to have a foster family already in there in the NICU and then have that be in a situation where biofamily is maybe ready but doesn't get to take their baby home, and the impacts that we heard about earlier that can have on bio moms or bio families' health as well. So it is just far more complex than like identify a foster family from the beginning so they can be here all the time. Well, maybe support that bio family in getting what they need so that they can be here when the time is right too. So there's just so much that goes into that. And I just wanted to name that caveat.
Yeah, and I'd agree. I've actually had the experience where we've had a foster family identified and trained and been there quite a bit, and the family was able to reach their goals and ended up going home with the family. And I think that's probably the more rare story, but for that foster family too, they gave a lot of time and really, devoted a lot to learning that care. And hopefully they would be just as willing to do that again for medically complex infant in the future. But maybe that puts a little bit of a bad taste in their mouth, and then they don't do it in the future too. So I agree that we definitely need to, when we know they're going to go with foster family, then to get them involved as soon as we can, but that it's not the one size fits all. And I will say, for the one baby I said that was there that ended up going home with mom, that was actually a much smoother process because it was determined pretty early that DHS was no longer involved and that mom was going to be the primary caregiver, and we were able to give her a lot of extra resources and a lot of extra training, et cetera, that I think were really successful.
Bert, I got a question for you. For families who we have this kind of lead time where they're in the hospital for a period of time, and whether they're going home with birth family or foster, can you talk a little bit about how KICS Clinic can get involved before baby discharges? And can you talk a little bit about your efforts to keep birth families involved, even when kiddos don't discharge home immediately with that birth family?
So one of the things that'll be done is that there will be a warm handoff referral to both our nurse care coordinator and our social work team at KICS. So they'll be aware of the referral and they can have back and forth communication about that baby's social needs as well as their medical needs. In terms of biologic family engagement, we have been explicit with Arapahoe County that we intend to engage biologic families in these appointments at KICS Clinic, and they're very supportive of that. And really think that that will be, from a safety and court standpoint, possible in like 99% of the cases. And what we have agreed with Arapahoe County and the commitment we've made is that some families have to have supervised visitations with their children. And essentially Arapahoe County DHS has granted KICS that we can be the supervisors. And we have committed that we will always have a staff member present. And Arapahoe County DHS says that will meet their compliance. So that's one step we've taken. As part of our intake process, our social worker will make a minimum of 3 attempts to contact the biologic family to let them know that their child is scheduled to come to KICS and when that appointment is. We also have permission to send the AVS to the biologic families, the after visit summary. And we are prepared to engage the biologic family in person or via like telehealth or, other things, because it can be really hard to get to all these appointments, and we recognize that. So those are some of the things that we have done. Oh, and I guess the last thing is that we wanted to be able to have a conversation with the families about the KICS Clinic and that program, and also about like early intervention services, and when would an appropriate time be to do that? And it's not at removal. And So there is something called a links meeting that occurs about 7 days after. And it's the first time that the family gets to kind of go through what the concerns were very concretely and what actions will have to be taken by them to be reunified with their children. And our social worker will be able to join those links meetings and have an opportunity to talk to the families. So those are some of the steps we've tried to take.
And I'll just add, separate from the KICS clinic, but for our special care referrals, obviously not nearly as an in-depth process and a little bit different population, but we found just anecdotally really high success if a child is being referred there for follow-up care for either one of the clinic nurses or myself who's going to see them. If we make a connection with them in the unit before they go home, the adherence to follow-up appointments and just the family's overall, connectivity to the clinic is a whole lot higher. So we try to do that whenever possible. Obviously, it's an extra task, but we have found success with that.
So the one, I think, probably bifurcation in the algorithm that maybe we didn't explicitly state is that, as we're doing this transition project from a CHoSEN hospital to these outpatient settings, infants have to be relatively medically uncomplex to go to Bird's clinic. So if a baby is very preterm, so less than 28 weeks, or requires additional medical technology beyond just a low flow nasal cannula, they can't go to the KICS clinic. It's thinking about, those patients that are eligible to go to our regular child health clinic. Those are the same parameters as sort of medical criteria to go to Bird's clinic. Then otherwise, they would have a different pediatrician, but then can follow up with Kathleen in the special care clinic for multidisciplinary care, sort of a medical home for pediatricians that need that additional support for those medically complex infants. All right. Well, thank you so much, Bird and Kathleen.